Ladies and gentlemen, thank you for joining us today for this Vattikuti Foundation Webinar Series program. It's a topic of interest to me on how to make prostate biopsy comfortable for patients and more informative for clinicians. Joining us today is Dr. Wooju Jeong from the Vattikuti Urology Institute at Henry Ford Hospital in Detroit, Michigan, and Vattikuti Foundation CEO Dr. Mahendra Bhandari. And this is a topic of interest to me because I've had a couple of prostate biopsies at the Vattikuti Urology Institute. One was several months ago and one was a couple of years ago. And I've noticed a difference. The first time it was a little more uncomfortable than the second time. So I think there must be some new technique that Dr. Zhong is going to be talking about. And without any further word, I'm going to go ahead and let Dr. Bhandari take over the program.
Thank you, Dr. Wooju, for sparing a Saturday for Vattikuti Foundation. Participants from all over the world. How Vattikuti Foundation chooses subjects for webinars, because this is tsunami of webinars during COVID times, and we are very possessive of time our viewers devote to us. Prostatic biopsy is the mainstay for managing managing prostate cancer patients, particularly so those who opt or the surgeon decides for an active surveillance or non-surgical or watchful waiting. Now, I have been privileged to do a clinic with Dr. Menon for the last 14 years since I'm in the United States. And that is a barometer for me what a prostatic biopsy used to be from patient end and what it is now. As you know that the global figures of what called systemic inflammatory response or SIRS following prostatic biopsy, which was transrectal predominantly, was 6 to 14%, which could be a mortal complication. 50% of them would have hematuria or hemospermia. And Henry Ford was no different at that point in time. Dr. Menon and his team, and particularly Dr. Wooju Jeong, brought in the new era for prostatic biopsy. And it can be judged from two parameters. One of them is that how many course surgeon is able to take for a wider sampling of prostate cancer. As you know, it's a multifocal disease. And second thing is how comfortable the patient is after that. I have seen a lot of cases of patients, which I'm sure Dr. Wooju would agree, would say that if that is the kind of biopsy I have to have, might as well you remove my prostate once for all. It used to be so painful. It would be so uncomfortable to have a finger in the rectum. At the same time, they'll go into retentions and all kind of problems. What I witnessed for last couple of years or 3 years is that we have a three-dimensional prostatic ultrasound by Coelis, and there's another Dr. Wooju is going to tell, with which they do a biopsy as if a colonoscopy is done. And I have had colonoscopies, and I see that I go to sleep, and when I wake up, only as if I just had a nap. And that is the level of comfort. At the same time, Dr. Wooju is going to give you data that how it has prevented the need for inconclusive and rebiopsying these prostates in order to get a conclusion, particularly in a dichotomous situation when the PSA is persistently rising, but the sampling doesn't show any prostate. There are new prostate cancer. There are lots of new dimensions of multiparametric MRI, fusion biopsies. So that's why I thought this is the right time to bring the best practices to urologists, that how it has changed, made a paradigm shift in the case of diagnosing and managing prostate cancer. there could be no other person than Dr. Wooju, who is, for your information, we have been working together for last almost, he joined department a couple of years after I did, and he is a longitudinal fellow with us and then on staff. And to give you a secret, my own impression, he is one of the finest robotic surgeons uh, I have seen, or who has been recognized by Dr. Menon. Thank you, Dr. Wooju, once again, and look forward to have lessons from you about what was prostatic biopsy before you guys turned the corner and what it is now. Dr. Wooju Jeong.
Thank you, Dr. Bhandari. I think I can share screen now. Hi, I'm Wooju Jeong. Well, thank you for inviting me for like this talk, Dr. Bhandari and Vattikuti Foundation. And then thank you for their coordinating Giovanna and Dave. Thank you for your support. So, well, I think Dr. Bhandari can like so introduce myself like a kind of like a bigger than what I have done. So I've done this like a new like a coilless machine system, which is like a three-dimensional biopsy system, ultrasound the system platform for the last 3+ years. And then I just want to share my experience about the coilless biopsy, how we first they utilized that machine. Then today I'm going to talk about if I want to do like transperineal biopsy, where can I start, and then how I set it up and how make it comfortable until we move on to the next step. That's what I want to talk. So, well, I do have like a very minimal data for the outcome, but it's more like the practical thing. So, and then for the data, I think we do have like a lot of data that coming up about this, so we can get the data experience from there. But the thing is where we start. That's what I wanted to focus on. So I'm working at Vattikuti Urology Institute, Hanford Health System in Detroit, in Michigan. And then okay, here you go. I don't have any thing to disclose today. And then originally I did the fellowship training in 2008, 2009, and I moved to Vattikuti Urology Institute in 2009, and then start working as a senior staff in 2013 now. So we set it up like the transperineal biopsy when I was fellow, or around like 2011, 12. Since then, we've been doing transperineal biopsy in our practice. So we have a 3 key person in our institution, as you know, Dr. Menon, who developed like a robotic the urology surgery program, first in the world. And then we had a good charity from Mr. Vattikuti. And also another key person is Dr. Mahendra Bhandari, who set it up like a data base. It's called the Robot Surge. It was like only at the beginning after we started like a robotic program here, and then we published it, many papers utilizing that Robot Surge database. Now he is also doing like a Vattikuti collaborative the data set up internationally. So, well, without like those data, we couldn't publish them in many papers. Still, we are using that data set up very nicely, very well. So in our institution, we have several options for prostate biopsy. The outpatient, like office trust guided prostate biopsy, still we're doing. And then also we do MR fusion biopsy, which is gonna go through the transrectal. And then also we do transperineal biopsy in outpatient clinic. And then I do a transperineal biopsy in the operating room under IV sedation. And then that machine has MR fusion capacity. So I also do an MR fusion biopsy in the operating room under IV sedation using coilless machine. So today I'm going to start talking about the transperineal biopsy in the operating room under IV sedation. So main indication going to be active surveillance for the prostate cancer for low risk or low volume intermediate risk prostate cancer patient. I do the mapping biopsy in the operating room, and if I have MRI available, then we can connect his a PACS system, download imaging, and then I can do MR fusion biopsy to using MR imaging. And then also I do the previous negative prostate biopsy patients. I do a saturation biopsy transperineally. And then, well, when I offer either office the biopsy versus the oral the biopsy, transperineal biopsy, some patient wants to get this done under IV sedation for comfortness and or anxiety because of the anxiety. And then another thing is like physician preference. The main is, so before moving forward to office transperineal biopsy, I think until we get the learning curve, you can try a few transperineal biopsy under IV sedation until we get used to it, and then that's one the main that's one of the possible indication for operating room transperineal biopsy. So we do have three ultrasound platform in our institution. One is the main talk of the today, which is coilless Trinity system, which has a 3-dimension capacity. So we can make a prostate gland model in the 3-dimension, which also like we can make a target in 3-dimension inside of the model. So, and then one of the unique technique, it's just similar to the MR fusion biopsy, like Artemis system, which is tracking a needle. So Artemis is like the physicians making a needle track, like using the people like a mouse. But this one is detecting the needle automatically. So it leaves the needle track in the 3-dimension model. So which going to be overlapped with the prostate model. So which is a unique technique. I like this ultrasound because of the that cool technique. Imaging quality of the imaging is not like a super duper high, but I like that the 3-dimensional model very, very much. So I mean, of course, like the BK ultrasound machine is kind of like a high standard for ultrasound imaging quality. So I usually say that like and then another the ultrasound setup is Mindray, which is very convenient to using it. And then it's the size of the laptop, so you can carry on like anywhere you want. Like the patient does not need to come to the procedure room. We can just bring it to the exam room, and then we can get this done on the bedside. It's very portable. And then, but quality of Mindray, I usually say that this is the SD quality. And then coilless ultrasound machine, the imaging quality, I usually say like a HD quality. And the BK ultrasound machine quality is I usually, I just tell that like a 4K or 8K quality. I like it. So there's one more better one, which is a Canadian company. The name is in my brain, but that is like a super duper nice system. So anyway, so that's one of the benefit of a coilless system, which is to make 3-dimensional model needle tracking they make the target lesion inside of the three-dimensional model, and then we can confirm that needle is going through the target lesion using the needle track the system. And then no matter whatever you're using it, I think one of the mandatory equipment to have is a biplane probe. So no matter what, like a coilless machine, it comes with as a packet, and the PK ultrasound machine, you gotta need like a biplane side fire ultrasound probe. Mindray also come with side fire like a biplane ultrasound probe too. So no matter what any system you can use it, but you need this probe, of course. So first, before start like biopsy, do I need to do give antibiotics? Technically, no. If you plan to do just basic like a 12 samples or 22 samples of prostate biopsy, technically you do not need it because this is like a skin poking, and so technically you can just like the skin prep well, and then that's all you may need it. However, my personal preference, I give NSAID, like a first generation cephalosporin antibiotic, even for like a prostate biopsy naive patient. And then also, of course, like a saturation biopsy or mapping biopsy, even like MRI target biopsy plus systematic biopsy, I usually give NSAID or clindamycin for penicillin allergy patient. I mean, though, because I poking so many times of needle, I feel more comfortable to doing it. So one of the thing I wanna talk about later, but the thing is, sometimes on the IV sedation, patient feels pain a bit when needle is going through their skin, and then patient sometimes moves, or some patient has sleep apnea, that they coughing during the IV sedation. In that case, probes move and they push out the probe. When we push, we probe in and out, my feeling is the contaminated lube from inside of the rectum gonna come sometimes coming out, and then rub around the anterior aspect of the anus. When we go through the needle through it, that's a potential source to have infection. So when we have infection, that could happen. So just in case, I just give NSAID and then also, or like a clindamycin for that situation. So that part I'm going to talk about more. So and then next, the positioning. So that's one of the first the key point of today's talk. So normally, like on the left side screen, like we usually put a dorsal lithotomy position like that on the left side, like a little bit like a raised leg as we do a cysto kind of stuff. That's good enough to expose perineum to get the biopsy. But I like to do hyperreflection as we seen on the right side of the screen. The reason is if you do hyperreflection, the pubic rim gonna be moving up, so we can have better access to anterior prostate gland portion better. It doesn't matter for wide pelvis patient, the small prostate gland, doesn't matter. No matter what you position, you can do it. But if you have like an African American here, usually they have the narrow pubic rim, like a narrow pelvis, or big prostate gland, which is hiding underneath of the pubic rim. You cannot get that, which is one of the benefit of the transperineal biopsy, which is we can get the anterior, the sample, but that's gonna be go away. So I like to do hyperflexion of the leg, a hip joint, so that we can access to the anterior gland better. So this is one of the tip, the positioning. A skin prep, scrotal support using the sling with the tape and lift up the balls out of the way, and then shaving, and then using a chlora prep, just a single thing. And I don't do drape. That gonna be like extra minutes. We can just get rid of it because we're gonna do the needle access only for the perineum. That's all. That's good enough. And then the next wall table setup, I usually using 2 biopsy guns. The reason is I don't have to do it, but I swish the needle into the formalin jar in the sample cup rather than like a swipe on the paper and then take it out later. Because anyway, it's gonna take a while to get the sample off from the biopsy needle. So usually like they spend more time to get the samples from the biopsy gun rather than actual getting a sample from the patient. So they like struggling like a swish something like that. So if you're using 2 biopsy guns, it's going to be make it more efficient. So that's why I prefer to using 2 biopsy guns. I mean, you don't have to do it, but I like to do it for efficient, like a quick, like a back and forth. And then another thing is endocavity balloon. Well, that's one of the key parts of the transperineal biopsy. But you don't have to do it. I'm going to explain how to figure out that part. So endocavity balloon is kind of the balloon up to 60 cc of saline inside that can be pushed up the prostate gland, and then they're going to be move the prostate gland center of the grid. So you can get access to the prostate gland very comfortable. So that's what I like to use. If you don't have it, you can use a normal condom, no problem. And then of course, using grid. And then put a 10 cc of lube inside of syringe, and then usually putting into the endocavity balloon or like a condom, so that like you can push in. It's very easy to squeeze inside. And then water, because I swish the needle tip in the formalin. After that, I wash out with the saline or water twice. And then paper and pen. That's I'm going to go through one by one. So again, ultrasound probe, you have to use a biplane ultrasound probe. The model name is like 88484 BK machine, or next generation, like a newer machine has a different name, like a complicated E14CL4BE, something like that. So anyway, that's like a for 8,000 model of BK machine. 8848 is like the previous generation called the Flex model. So the Flex model, between the Flex model and the new generation has like whether it has ML fusion biopsy capacity or not. So the new generation like is 14CL4B, like a next generation of BK machine has ML fusion biopsy capacity. So you can do technically office the ML fusion biopsy using this transperineal biopsy. And then a probe condom, I mentioned about it. Why I want to use a probe endocavity balloon rather than probe condom, because you see like in a sagittal section of the diagram, schematic diagram, usually like the part of the rectum is like in between the prostate apex and the muscle, like sneaking in. So always like to access to the posterior prostate, or even like a base of the prostate gland, sometimes like a needle feel like going through the rectal wall. It doesn't matter really, but feel like a patient has more the urge to defecation after the biopsy. Feel like they want to having a bowel movement, but nothing coming out. I think that because of the bleeding from the rectal wall when we pass the needle through the rectal wall. And also like potentially there's a small chance that get like a contaminate a needle before getting into the prostate gland. So I want to get this out of our way to get to the posterior prostate gland. So if I use an endocavity balloon on the right, on the left downside, a ultrasound imaging shows that like a little bit dark, like a hypoechoic lesion, which is water pushing up the prostate gland on the way. So if you're using this endocavity balloon on the grid, the prostate gland is going to be moved up in the center of the grid, so that we can access the peripheral zone, posterior peripheral zone very easily. That's why I like endocavity balloon. But before, I've been studying more recently. Before, I used just probe condom for the last couple of years, but no problem. The thing is, you know, the most of the needle we using is probably most of you using a Bard company thing, which is like the beveled needle. Beveled needle always going skiving it. Means like you know, usually it doesn't go straight. It just bent toward one side, where the bevel side, I mean upper side of bevel, right? So actually, you know, I usually tell a resident, teaching a resident that this is the like art of utilizing this bevel, like curving it. So one of our like a famous renowned fellow, Dr. Sud, used that term, like a curving it, as the cricket the term, like googly shot. So it's just like a, you know, the curve ball, like a bounce and then bounce out like a very awkward, right? Like a very angled. So what I do is when I penetrate the skin to the rectal wall, I'm skiving up toward the mid gland of the prostate gland, and then turn the needle downward. They're gonna be curved down after passing this rectal, like a rectal portion, and then aiming down to get to the posterior prostate gland. We just like joking it during the biopsy. That's called the googly shot. So in that case, we can use a probe condom, like a normal probe condom. Prostate going to be down and the rectum is on the way, but still we can get the posterior prostate gland without any issues. That's one of the things. Googly shot, that's one of the key point. And then next one is the grid. Usually using a square shape of grid for this coilless biopsy attached to the ultrasound probe. And then sometimes I use the like a narrow the needle guide. This one I use it for on the right side one, like a narrow one. I use it for MR target biopsy because it has a 2.5 millimeter between the needle track versus like a 5 millimeter needle track on the for the skewer thing. So I want to more can get the sample so more delicately from the where I want to get. So I using both for MR fusion biopsy to combine the systematic biopsy plus MR target biopsy. I use both grid. For local anesthesia, well, the local anesthesia I'm going to talk at the last part of the talk. That's one of the key. For IV sedation, we can just do skin anesthesia. That's good enough. That's a conventional way we can do it. The thing is, here's the midline, raphe, that's where the urethra is. But again, I'm going to get more samples from the posterior mid. I'm going to talk about the template later. So I usually give a local anesthesia like this shape rather than like a triangle shape. That's going to be cover majority of the, I mean, most of the peripheral zone and then most of the transitional zone. So, and then even like a posterior peripheral zone going to be quite like a block. So, well, as long as needle past this skin with IV sedation, I think that's a sufficient amount of the nerve, the anesthesia. That's good enough, I think. Here's a template I use. On the right side, a template, I usually put this printed out and then attached to the ultrasound machine or attached to the spotlight on the the ceiling side, so that everybody gonna be like a communicate which samples this sample is going to wear. So this is like a template what I've been using for the last 10 years. Well, you can do like a 12 sample, that's fine. You can do like 18 samples, that's fine. But I like these the 22 samples. I make a column like a medial, lateral, and most lateral, and then a couple of samples each side from the base. So these samples, like around the 7 samples from the peripheral zone, and then the 4 samples from the base of the peripheral zone, and then I more focused on peripheral zone rather than the transitional zone, as you know. And then of course I want to avoid around the periurethral tissue to avoid hematuria. So in the case, again, most of them does not have any hematuria unless you hit the base of the bladder for the small side of the prostate gland. So anyway, and then we've been using it for the last 8 years, and then I add on one more sample recently. It's called the, it's not on the template here, it's called the posterior mid. This is very unique samples. I mean, some of our colleagues doesn't agree with me to get this sample, but I mean, this side is kind of unique. You cannot get it through a rectal biopsy. You only can get it when you passing the needle parallel to urethra. You're not hitting the urethra. You can get it. The reason is I want to know whether either like a posterior apex of the prostate gland, or if I want to know whether the patient has a disease at the central zone. If any cancer arising from central zone, they would have like the more aggressive feature than the aggressive cancer arising from the side of the prostate gland. I mean, unilateral disease. So that's why I started. Like I was just curious that I want to get like these samples, and then that's what I started. But I don't have any data how many patient had a positive from there. But I can tell patient that like unilateral disease, which is crossing the midline. That I can tell the patient. So anyway, this is a normal template. You do not need a paper and pen for this, because this is all one samples. But if it goes to saturation biopsy or mapping biopsy, that can be complicated, because I'm gonna get like a big size of prostate gland. I'm gonna get every single 5 millimeter samples from the overlapping with single spot. It's gonna take a while. I mean, it's very complicated. It's very hard. A2 like a double Z or something like that. So I don't want to like give a confusion. And then another thing is, one day when I didn't do the new setup, and then I did biopsy in 20 minutes for this, and then they still labeling it. So like a overall like a biopsy time took like a double because of the print out labels and then put the label in the system. Like, oh my God, that's crazy. So what I do is I don't need to know where the cancer is from, like either E10 versus like E9. I don't need to know. I just want to know where, so roughly like where is it from. So I usually get like every 5 millimeter distance, but I'm grouping it and then send to one jar. So this quality system going to be guide as you like the same manner as you pointed out. So if you point out like 1, 2, 3, 4, it's going to guide ultrasound probe as you pointed out, as you planned. So first 4 sample go to jar A. Next 4 sample go to jar B. So I just write down, and then once they collect the 4 samples, they scratch out, and then they're gonna move on to the next jar. So, and then me and the resident or assistant, or we just focused on the, okay, next one gonna be E8, E7, or I mean D7 or something like that. So before I was very aggressive to get like every single, like including the capsule, but nowadays I'm more focused on the peripheral zone, and then less samples from the transitional zone, even like a saturation biopsy. And of course, like as you see, like several samples from the base of the prostate gland, and then also like a posterior mid samples, either apex or central zone. I'm getting some samples from there. So called the W. So that's what I really do. So before moving forward, I'm going to talk one thing. So this ultrasound probe, as you know, the scanning like start from the posterior, like a rectum here, and then like a moving the scanning toward like a lateral, like this way, rather than like it doesn't scan like this parallel to the sagittal plane. It is scanning like a turning around, which means if you get samples from most lateral samples, if you do like a transectional imaging, you always feel like you hit the top of the imaging because that is close to the capsule. That's normal. So for the most lateral sample, and then when you see imaging, like a prostate gland gonna be like getting smaller, and then needle is almost like hitting to the capsule. That's what we normally see. That's what we are supposed to see. Again, like using a biopsy gun, because of the bevel needle tip, it is a kind of art of utilizing this skiving of the needle. So whenever you feel like, okay, most lateral samples feel like it's going outside of the prostate capsule, and then you can just like a bevel toward this side, and then it's gonna curve toward that area, the curving this way, right? So the curving this way, the moving down. So you can utilize that curving. That's one of the things. So. So I'm gonna just like turn off. So here's the final product, like imaging. On the left side, you see the needle track and the prostate model, which I show that like apex and base or something like that. And then the one imaging that this is from the one of the website shows that the MR target biopsy. You see the like a red dot is showing. Go through the MR target lesions, what they make, and then make sure the needle is going through the MR target. This target will have to make it based on the MR the reading. So, well, the MRI, like a radiologist can give us like a target lesion, like a mark it down on the imaging, but this cordless machine will have to make it on the system. I mean, in the system. So, and then this is a little bit tricky to put the needle and then scan and then wait until like it leaves the skin track to make sure this is going through the MR target. It is not showing up on the real time, unfortunately. That's what they been working on so far. Only way we know whether needle is going through or not is after we track the needle. So we'll have to wait until we scan through and then leave this mark. It will show up on the three-dimensional model that the needle is going through the target lesion or not on this model. And then, okay, we got the sample from the lesion. And then we're gonna move on to the next. A little bit tricky, but of course, like it is very, very like a comfortable once you see that the needle is going through the lesion, then okay, I got the good sample. So here's the I just demonstrated, right? So like a model how it look like. It's quite a cool. So if you see few samples going from the base of the prostate gland, passing through that. So one of the idea is base the prostate gland, also whether you can get some samples from the seminal vesicle prostate junction too, if you suspect for the T3 disease. That's one of the idea. And then before we start using Qualys machine 3+ years ago, first we set up using a BK machine. So basically all the equipment, what we're using is we use for brachytherapy. So this stepper is bulky, very stable, but too heavy, complicated to assemble it. But once you get used to it, this is like a stable stepper ever. It never moves at all. So I like it in terms of like a stabilized patient and then stabilize the ultrasound. Like it never moves. So I like it in terms of the stabilization, but bulky. So sometimes the OR call me like, hey, Dr. Zhong, come down and to assemble this because they don't know how to do it. Some nurse does not know how to do it. So in this situation, I recommend to put a Foley catheter only. For the procedure. That's using as a landmark. So every time, like put the ultrasound in the center, and then the market, and then on the grid, it's gonna be like a D in the center of the grid, and then that has to be Foley catheter should place at the D line right here. And then another difference between a coilless machine and then this the BK machine is like the manually rotating ultrasound probe. And then a grid attached to the stepper. It's quite stable. Like everything is like fixed. So that's a little bit different. So Foley catheter. Okay, so I used to put a Foley catheter for coilless machine because I've been using it. One of the thing is I postulate like at the end of the procedure, I because of the complication, as a part of the complication is urinary retention after transperineal biopsy. So I want to check whether they're passing urination or not before going home. So I fill up the bladder around the 150 to 200 cc in the bladder, and then pull out the catheter. That's going to be kind of like a fasten up the recovery time, like a shortening of their staying time in the recovery, so they can live early, they can pee better. Sooner. So that's why the reason. So two reasons. One is I used to use as a midline for the BK system, and then recently I've been using it to fill up a bladder to enhance like a discharge time. However, I feel like that's too much. Only for like filling out the bladder, that's too much. So these days I start hydrating the patient in a pre-op, and then the biopsy time it'll take about 40 minutes, and then recovery within an hour. If we give the bolus of the water IV before procedure and after procedure, and then their bladder is kind of full by the time end of the procedure. So these days I don't put a Foley catheter for a coilless machine, and then still BK machine I'm using it to utilize as a landmark for the midline. And then next complication about the transperineal biopsy. I mean, most of bothering stuff is urinary retention. So for the first 100 the transperineal biopsy patient for biopsy naive patient, we had about the 10% retention rate for 22 course, the patient. At the beginning, I did a 22 course. So which is like a kind of the similar number comparable to the other study, excuse me. And beside of that, the patient experienced LUTS and hematuria, some patients seeing a hematuria, hemospermia and infection. Infection is like a very, very low. We barely see infection. I had like a first 100 patient, I think I did a UTI, 2 UTIs out of 100 patient when I check it. But after that, I haven't had any infection since then. I mean, one of those patients related with like a kind of like a prolonged the polycatheter indwelling. So if a patient cannot pass urine, most of patients require either straight cat for a few days or a catheter for 2 or 3 days. Usually 2 or 3 days, you know, the most of patient passing urination, no problem. After like a bleeding stops, a prostate gland swelling come down. So that's what I normally do for those 10% patient. Leave polycatheter for 2 or 3 days and then try avoiding later. So that's one thing. So one of paper in the 2017 European Urology, it shows that the transperineal biopsy and transrectal biopsy complication rate. So urinary retention rate is about 0.6 to 6% the transrectal biopsy. That's one of the reasons why we need a transperineal biopsy. I mean, not for this. So I'm sorry, I just put the words back. So so I'm going to talk about like okay. So infection rate is after transrectal biopsy is about 1 to 17.5% after the transrectal biopsy. And then that's one of the reasons why we moving to the transperineal biopsy. That's funny. And then in the Michigan Urology Surgical Improvement Collaborative, we have kind of movement that we improve the infection rate improvement utilizing the culture sensitive antibiotic utilization and also like a double coverage of the antibiotic utilization. So after that, our Michigan, the infection rate after transrectal biopsy was from 1.19% to 0.56%. Yet still, you know, some patient like overall like a 1% of the infection rate in general. But instead, like an infection rate after transperineal biopsy is about 0% or 0.2%, very low. Even like most of them are having like a UTI or they barely have positive urine culture after that. So, I mean, infection is, I mean, safety. That's the main reason why we need to move on to a transperineal biopsy instead of transrectal biopsy. However, the urinary retention is one of the kind of like a headache side of the transperineal biopsy. But of course, like a number of samples, and then that's also like whether you getting samples from more transitional zone rather than like peripheral zone. That's one of the possible reason to causing a urinary retention and also like hematuria issues after this biopsy. So after that, so as I mentioned earlier, the Michigan Urology having movement to transperineal biopsy from transrectal ultrasound biopsy. So in our institution, we have a champion, Dr. Amit Patel, who kind of leading this office transperineal biopsy. Or we using either BK ultrasound machine or mind ray. So you can see a little bit different ultrasound probe, which is mind ray. And then we are doing under local anesthesia. And then here's a template where we get. So we getting the 6 from the apex and then 6 from the base of the prostate gland, and we getting more samples. So from the the lateral. So actually, like the anterior and then lateral gonna be get 1 sample. So posteriorly we get like a 4 apex and then 4 from base. So that's what we have been using it. So this is the one of the case of the 61 years old, the gentleman who had a little bit PSA patient, and the same thing, like a tape guards protect the scrotal hair, and then so one of the thing is lithotomy position in the office, you can use a stepper in the office, that's fine. And then one of the things is ask a patient to lift up the balls. That's like the best way to set it up. And then using ChloraPrep, and then Urozet the rectum to make them comfy. So this needle is one of the key using for this mind ray. But the thing is, this one is sliding up and down like a parallel movement. It's moving a parallel to the probe. So needle always going to parallel. So that's a little different, the needle guidance compared to like later I'm going to talk about precision point, which Dr. Gorin's group published before. So this one is going parallel. That's one thing I want to. So and then we're using a 17 gauge coaxial needle to guide the needle. So the thing is, this coaxial needle is penetrating the skin, and then it's like a skin and the needle gonna go moving like a parallel, move up and down. But you're gonna have technically, you're gonna have like one skin poke. And here's a needle. I mean, here's the skin block as I shown earlier, like a kind of U shape of the anesthesia on the skin. After that, we put the coaxial needle go through the skin, and then using a spinal needle, and then we giving a numbing shot, a deeper layer in the subcutaneous tissue, and then it's called like the prostate apex anesthesia technique. So that's a second. So here's the thing. So important thing is like numbing this subcutaneous tissue, but also more important thing is you will have to block around the muscle area. So most of the patient feel pain when needle is going through the muscle. That's one of the key factors. So it's all about the giving a numbing shot, and when you're doing office transperineal biopsy. Other than that, otherwise once you know how to put the like a poking a needle through it, I think it's nothing. It's nothing. It's all about how to do like a local anesthesia when you plan to do office transperineal biopsy. That's all. So biopsy template I mentioned about, and then so here's the one poke in the skin, and then we're gonna get samples from posterior prostate gland. So got it from the posterior. This is the apex. So gonna get like a sample from the apex. For the base biopsy, needle poking through the mid gland, like a mid portion of the prostate gland, and shooting from there to reach to the seminal vascular base of the prostate gland. For the anterior biopsy, so here's one of the tip that you see, they unscrew this the needle guide and then move up. But keep in mind that like we're gonna have a still utilizing a same skin hole. We just like a shift up with a needle and skin, shift up to access to the anterior of the prostate gland. Yeah, the patient is a little bit moving. So see, like you see, like a two skin poke on the perineum. That's one thing. So here's the one paper, the 2019 Journal of Urology. Dr. Stefanova published about it. So about 1,300 patient, 50% detection rate, retention 1.6%. And then antibiotic only like a 4 patient that took it, but only 1 positive urine culture. Good. So here's the one thing, like one had hypotension. So probably most of you had experience of the hypotension, like a kind of vasovagal reaction, or like a little bit like a blood pressure lower side, softer, or patient started sweating after biopsy. So most of most of them we accuse that like a local anesthesia, like a lidocaine going into the sinus, especially for the the apical area where the lot of sinus plexus are located. So when you're giving a local at the posterior apex or base of the prostate seminal vascular junction, that area, so we can, well, sometimes we give some local intravenously, and then patient experience some kind of hypotensive or something like that. So here is one of the tip. Until you get used to it, you're gonna do like a really good the local anesthesia without that kind of like IV injection. So that's what we need to kind of like get used to it, and then also like a covering like the local anesthesia around the pelvic floor muscle. Once you've done that, actually, this based on this paper, the prostate infiltration, like a needle procedure, it's not much like a, I mean, the biopsy itself, it doesn't not show much like a pain. The main thing is like a skin or like a anesthesia numbing around there, or when the needle is going through the muscle. That's mostly like a feel pain. But in our institution, what Dr. Patel found was out of 74 patients, most of the painful part, like annoying part, was like a local anesthesia. But biopsy itself, it doesn't hurt the patient much. This patient were not much like bothered. So most of the patients, if they need to do it again, most of them are said yes, they could do it again. They were willing to do it again, as long as you give a numbing shot properly, and then the sampling is not a big deal, so they will be tolerated. However, still, most of the pain score is about less than 4. It's not that much painful. So that's one of the finding what we found for the 74 outpatients. So another paper using like a precision point. This is the precision point, like the picture A, which is like the height is almost like a fixed, like you have 5 holes in there. So it is fixed. It doesn't, and usually we don't move like a pedal to do it. So once you fix it, usually it's a fit on BK ultrasound probe perfectly, and then doing one side and on the other side. So one of the unique technique, what Dr. Gordon showed us, is this technique. On the left side, the picture, kind of poking the same spot, but you angle to get a sample from the lateral prostate gland, anterior prostate gland, and posterior prostate gland, so you can get any side of the samples. It kind of like the movie, change the angle. So that's one of the key things. So, and then they focused on mostly like a peripheral zone, focused on the peripheral zone. Then they had a good outcome for the sampling thing. So that's one of the tip. And then these precision points sometimes doesn't fit on the ultrasound probe. And then, for example, like a coilless machine ultrasound probe, this is too big. In the case, we can just wrap around with a tape or Coban tape, wrap around, and then you can attach on it, that it will perfectly fit on. So that's one of the things. And then the last part of the talk is about like giving a local anesthesia when you're doing in the office. So again, like when I do IV sedation in the OR, I usually giving a numbing shot, self-cue numbing shot. The another option you can do is, well, normally what I do is for transrectal biopsies, you do as a prostatic nerve block, PPNB, at the posterior apex, and then prostate seminal vascular junction. That's another option. And another one, Dr. Gordon briefly mentioned about it. If this is not working well, that you can do like a, the deep perineal nerve block, which is like, main branch, like right here, medial to the ischio tuberosity. That you can put a spinal needle going through it to give a numbing shot. But this procedure is kind of uncomfortable. Like they're gonna have a more pain while giving a numbing shot to put it there. So, but personally, I don't have any experience for that. But mostly what I do in our practice, what we do is skin block, like number one here, like a U shape. Usually do U shape because I don't do like poking at this urethra. I don't do it. So U shape is good enough. And then also giving a numbing shot around the periapical area next to the muscle, like a pelvic floor muscle, before and after, like a that area. That's where I more focused on to give a numbing shot. And then I think that's a good effect. So here's the briefly like showing that like this is like the sub-Q perineal skin plus prostate apex. So local anesthesia infiltration pains scales, I guess, like over 3, but no procedure that's good enough, like less than 3. So that's what we normally do it here. So take home message, I think almost like a 1 hour. Sorry about the like a late Saturday evening in India. Take home message. So oral transperineal biopsy is set up for saturational mapping for sure, and then MR target biopsy you can do it, or this setup gonna comfort the patient and also doctors. So we will feel more comfortable until we get used to do a transperineal biopsy. And then we're gonna move on to outpatient transperineal biopsy for prostate biopsy naive patient. That's what I think. And then again, like a transperineal biopsy, it's all about the like a local anesthesia. That's all. So cordless machine, I just joking at the end. So cordless machine has showing it's sometimes the machine himself, he thinks that he's too smart, that sometimes giving us a lot of error message. So I tell the resident that like, okay, cordless machines are all about like how to handle the machine, like a programming, and then the tips and tricks how to figure out the error message. That's all about the biopsy. And then the office, like outpatient transperineal biopsy, all about the local anesthesia. Once you give a good anesthesia, and then the rest of them, like a patient is tolerated and does not have any problem, we should avoid like any uneventful situation, like an IV injection of the local anesthesia. That's all about it. So thank you for your attention. Thank you. Any questions?
Thank you, Dr. Wooju. I have some questions. Number one, it was a great, you clarified most of the doubts, but as a moderator, I was constantly generating questions for you.
Yeah.
I understand you correctly, in your practice, you have replaced transrectal biopsy 100% to perineal biopsy. Am I right?
Well, I mean, we have some leaders. So for example, like me, I'll do the office, even like an office transperineal biopsy, I'll do like 100% transperineal biopsy, yes.
Second question is, what is the protocol you follow for MR fusion biopsies or non-imaging supported biopsy? I assume everything is ultrasound supported biopsies, but are there any different protocols you follow according to the case you have?
So, well, MR fusion biopsy, doing it when we do have like a MRI imaging available, and then it shows MR target lesion, like a PI-RAD 3 or higher lesions, and then I'll do MR target biopsy on top of the systematic biopsy.
Another question I have is, one of the question box, one of the participants asked a question, how do you decide on number of codes? Is it according to the volume of the prostate will you see,
Yeah,
or-
so that's a very good question. So technically, like, you know, the prostate biopsy naive patient, we do not have to get like 23 samples, but well, my philosophy is like, you know, as long as patient is not bothered, why not? Like, why not? Also, I mean, of course, like there's a small chance that increase the retention rate, but the 23 samples, that's mainly like I do for prostate biopsy naive patient. But if the size of the prostate gland is too small to get 23 samples, I usually skip the most lateral samples. So in the case, it will be like a 4-4-1 maybe, you know, it's a 6. So 16, the 17 the samples. And then for the saturation biopsy, I get from every single the slot and the grid overlapping with like a grid. Feel like up to 40 cc of the prostate gland, I'm getting around the 3 sample plus a couple of more samples. But if you go more than that, I feel like I'm getting 1 sample per 2 cc of the prostate gland. For example, like if I do biopsy for 60 cc of prostate gland, I'm getting at least 30 samples, slightly more than that, 30 samples.
There is another thing, though this webinar was not structured for general population, but I see some of the general people, non-urologists in the audience. For their benefit, could you give a concluding remark that they don't have to be apprehensive with prostatic biopsy, and as and when they are advised by their urologists, they should submit them to biopsy with absolute assurance that it is a safe procedure?
Yeah, well, first of all, like, you know, also like, you know, transperineal biopsy has a different type of complication after the biopsy, but the most important thing is like infection rate is significantly lower compared to transrectal ultrasound biopsy. And then that's the main goal. That's the main goal. So the post biopsy sepsis rate is way lower after transperineal biopsy. That's a big movement. I mean, other than that, I don't have like much like a comment for that. So that even saturation biopsy or mapping biopsy, as you do more and more prostate biopsy transrectally, every single chance infection rate gonna be up to 2% every time. Like if you do more than 5 transrectal biopsy as part of the active surveillance, the infection rate is over 10 to 15% higher to get a sepsis after the biopsy. So active surveillance program, I think we will have to go to the transperineal biopsy. I saw like one of the question chat box. I saw that like the rate of the detection rate was 52%. Actually, no, when I did 23 samples, the detection rate was over 70%, 70%. So you know, that is 48% from the 12 samples in the office, which is like a similar to the like a national average. They're quite comparable. I just wanted to clarify that. If I get the 23 samples, the detection rate is over 70% based on the first 100 patients.
Thank you very much, Dr. Wooju, for a wonderful discourse. And I will hand over to Dave for closing the webinar. Thank you very much.
Thank you, Dr. Bhandari, and thank you for the attention for the audience. Thank you.
This has been a very fascinating subject today, Wooju. Thank you for all of your work in developing this presentation. We've had many comments in the chat box on people that have been viewing this that have really appreciated your efforts today. So.